Dana Miller presents Over-the-Counter Analgesics, Who, What, Which, and How Much, featuring Paul Christo, MD, and Melissa Gabel-Alvarado, FNP, discussing patient profiles and dosing. Now here is Dr. Paul Christo.
We're facing a daunting opioid epidemic that the government has declared a public health emergency as of October 2017. For example, opioid-related overdose deaths have increased by 80% from 2012 to 2016. An average of 40 people die in the United States every day from a prescription opioid overdose. In response, the Centers for Disease Control has issued guidelines for reducing opioid misuse, abuse, addiction, and overdose. We're here today with Melissa Gabel-Alvarado, talking about patient profile and dosing. Tell us, Melissa, about your approach for treating the patient in pain.
The first thing I do is try to figure out where their pain is, when it started, how it affects their life before beginning any therapies or treatments. The majority of patients can be handled through some cognitive behavior therapies, some over-the-counter non-opioid medications, or some interventional pain treatments before moving forward to anything stronger such as opioid therapy.
Mm-hmm. Those are good points because the CDC guideline mentions non-pharmacological therapies as well as non-opioid therapies. How effective have you found those non-pharmacological therapies to be?
When I get the cognitive behavioral therapy or the psychological behavior therapy in addition to the non-opioid therapies, I tend to have a very high success rate for patients that really want to be rehabbed versus patients that are more interested in not proceeding further with alternate exercises or work-life balance.
I've found that it's not easy for me to persuade patients to do CBT or cognitive behavioral therapy. How do you persuade them successfully to do it?
Well, actually, for the past 3 years, I worked in an outpatient psychiatric facility.
There you go.
I had a lot of experience working with patients that didn't have financial resources, and we didn't have pain management specialists in the town that I lived in. So that kind of left us with that alternative. So I had a lot of experience with that prior to working in a pain clinic where we have alternate resources.
Got it. One of these recommendations focuses on the importance of discussing the risks and benefits of opioid therapy with patients before initiating treatment or while receiving an opioid for pain. How do you do that in your practice?
So I am very honest with them that, it's all over the news every night that we have an opioid epidemic, that the risks involved with it, and the worst case scenario is overdose and or death. So I am very, very honest with them about the potential for addiction and discussing that if at some point they want to come off of this therapy, it is very difficult and a very lengthy and dangerous process. I also discuss the benefits of it, which include you will get pain relief, but that this really is not intended for chronic or long-term treatment or therapy.
Another recommendation is to use immediate-release opioids before we introduce extended-release opioids. This is different from the past because in the past, based on the literature and common practice, we were advocating the use of extended-release opioids before immediate-release opioids. Have you shifted your practice, or was that always your practice? That is, always using immediate-release before extended-release opioids?
So that's always been the practice there.
What about prescribing the lowest effective dose and cautioning patients to avoid doses that are certainly higher than 90 morphine milligram equivalents per day?
So one thing that I do is the honest discussion that when we get above a certain level, the risks involved in prescribing more medicine or stronger medicine or more frequent medicine also increases the risk of adverse effects, including the opioid overdose, furthering the addiction. It is a very difficult discussion, especially when the patient's saying, but I'm still not getting pain relief.
That's right.
Still feel like I should be feeling better. So at that point is when I try to say, look, what is your expectation for pain relief? Are you looking for 100% pain relief? Maybe we need to have a realistic expectation on it. And is 50% sufficient for you to continue a very healthy lifestyle? Or, are you expecting 100%? And maybe we're not meeting together on their expectations of pain control and pain management.
It's very challenging. Now, a third recommendation is to use naloxone. in certain patients who are at higher risk. Who are those patients in your mind?
I prescribe naloxone to any patient that's on chronic opioids or at that close to that top morphine milliequivalent dosing.
Now, in other words, if a patient is already on 90 morphine milligram equivalents or is also concurrently using a benzodiazepine, I mean, are those the instances when you're saying, all right, now I need to prescribe naloxone to you?
Yes. So when they're getting close to that 90 morphine milliequivalents, we are prescribing naloxone. Now, we are very, very strict in our practice about allowing the co-prescribing of benzodiazepines and opioids. So, but anybody that does have an indication with a psychiatrist on board prescribing the benzodiazepines, I automatically give them a prescription for the naloxone.
Okay. And then finally, what is your stance on urine drug monitoring in patients who are on opioid therapy? Because the CDC guideline is saying, okay, I think you need to go ahead and do urine drug monitoring before you initiate therapy, and then at least once a year.
Absolutely. I do agree with it. I think it gets a little tricky when we're doing urine drug testing at every visit. Like our clinic in particular requires every 3 months for anybody on office visits for anybody on chronic opioid therapy. Mm-hmm. And if you're drug testing them every time that they come in, I think it's a little redundant, and the patient's aware of that.
Yeah.
So I agree with the definitely before therapy urine drug screen and once within that next 12 months.
Let's now talk about the case of a 48-year-old man with pain from a left wrist sprain. X-rays of the hand showed no fracture. He carries a recent diagnosis of stage 1 chronic kidney disease based on estimated glomerular filtration rate. He's otherwise healthy and doesn't take medications. The pain has persisted for 6 weeks, and he feels that it prevents him from typing more than 15 minutes, using utensils, or working in his wood shop. His job entails a lot of typing, so he's been taking piroxicam, known as Feldene. It provides 50% relief of his pain and allows him to work and function. Acetaminophen wasn't helpful. He's a recovering alcoholic for 2 years and does not want opioids. His nurse practitioner has advised him to stop the NSAID, though, over concern related to his chronic kidney disease, but he refuses. So focusing on patient-centered care and treatment goals, what would you tell him about using the NSAID?
General medicine text and nephrology subspecialty guidelines recommend avoiding NSAIDs for most patients with chronic kidney disease.
Right. So in this case, how do you personally feel about using an NSAID, though, in a patient with chronic kidney disease? Because, as you mentioned there, it's not recommended, yet it can be quite effective.
As long as the patient is has a nephrologist on board that is monitoring their chronic kidney disease, and we're doing intermittent labs to make sure that there's not any progression or severe fast progression of chronic kidney disease, I feel that it is appropriate and can be very beneficial to these patients.
Very good point. What's the mechanism behind the possible progression of his chronic kidney disease?
The NSAID inhibits prostaglandin synthesis, which decreases renal blood flow and can lead to sodium retention, edema, hypertension, and hyperkalemia.
Now, in this case, the patient wants to increase his dose for greater relief and better functioning. What do you recommend?
Well, I could consider a trial of 14 days of an increased dose to determine whether his pain is better managed and his function improves. If no benefit ensues, then would recommend reducing the dose.
You mentioned a trial of 14 days of an increase in dose, but is that long enough? I mean, do you sometimes extend that to a whole month?
I can, and I have. Remember the black box warning about the risk of serious cardiovascular thrombotic events, including MI and stroke. The risk appears greater at higher doses, so I would strive to maintain the lowest dose.
Mm-hmm. And do you tell patients that?
So I try to be very honest with the risks involved in all of the therapies, even if it does invoke a little bit of fear.
Do you feel like these black box warnings related to the cardiovascular risk, gastrointestinal risk, induce fear?
Unfortunately, I don't. Mm-hmm. I'm not so sure that the patient, and maybe it may be my patient population, doesn't actually comprehend that the risk is with other organs or other problems that may cause problems down the line in the future. Unfortunately, they're focused mostly on the here and now and the relief of their pain.
Mm-hmm. Yeah, absolutely. Is this going to reduce my pain first and foremost? There's another black box warning I think you touched on related to GI. What is that related to specifically?
So there is also a black box warning related to adverse effects such as bleeding, ulcers, and stomach or intestinal perforation. Although the patient doesn't have a history of peptic ulcer disease, GI bleeding, and isn't an older adult, it is important to discuss the GI risk with this patient as well.
Mm-hmm. What do patients typically complain of? Do they complain of reflux or heartburn or stomach bloating? What is it that they typically say?
Heartburn.
Heartburn.
They definitely complain of heartburn. That's the most common GI problem that I see.
Now, the other question that comes up in a patient like this is, when do you add a proton pump inhibitor? For example, if he's going to continue to use the piroxicam regularly, at what point do you do that?
So if the heartburn becomes consistent, you may consider it after a month or so if continued therapy. Some practitioners would wait until he had GI symptoms and then add the proton pump inhibitor. The effects of NSAIDs on gastric mucosa have been estimated to occur in about 15 to 30% of users. The mechanisms by which the NSAIDs cause ulceration in the stomach include contact irritation of the epithelium and suppression of the prostaglandin synthesis.
We talked about the use of a proton pump inhibitor in this patient as a GI protective agent, but there are others. Let's start with misoprostol. Have you used that before, and do you find that it's effective?
I have used that with patients, and I do find that it's effective in helping to prevent some of the GI complications as well as relieving the GI symptoms that the patient has.
What about the use of H2 blockers?
I do use H2 blockers, and I have had success with those, especially because they are affordable and available over the counter. So I use those in patients that either don't take H2 or don't take proton pump inhibitors or cannot afford them for insurance or other reasons.
Have you found that the H2 blockers are less effective than the proton pump inhibitors or not?
Actually, I have, depending on which one. Some of the ones that have multiple dosings in a day I have found that are less effective, but I'm not sure if that has more to do with patient compliance of taking them regularly.
And then finally, what about switching to the COX-2 inhibitor? The only one basically that's available in the United States is celecoxib. When would you do that?
After the patient fails, if they tell me that they're not getting any relief from the traditional NSAIDs, such as the ibuprofen or the naproxen, I have switched to the Celebrex, and I have gotten great relief from that. I have not seen, as of yet, any of the side effects that I have seen with some of the ibuprofen with the GI upset. And the patients tend to like it.
Okay. Now, in order to reduce the adverse effects of NSAIDs, we try to use the drug with the shortest half-life at the lowest dose for the shortest period of time. This patient is taking piroxicam, Feldene, which has a very long half-life of about 50 hours. Would you suggest a different NSAID in this patient?
I would suggest trialing an NSAID with a shorter half-life, such as ibuprofen. This would reduce the systemic exposure to the NSAID and thereby lowering his risk of adverse effects related to the GI, renal systems, cardiovascular system, and the hematologic system.
Okay, now in this patient, you see him back in about 3 months, and he's got significant relief from the NSAID. He's now able to type, he can work full-time, work in his wood shop, which he loves. And he's now, though, taking valsartan, known as Diovan, an angiotensin receptor blocker for hypertension. So he's developed hypertension at this point. How would your management change?
So I would tell him that the NSAID can interfere with the therapeutic action of valsartan. He would need to monitor his blood pressure more frequently, as well as his electrolytes, such as sodium and potassium. And his renal function, such as his BUN and creatinine, would need to be monitored more often.
Now, more often means what? In other words, would you have him come to see you at this point every 3 months or twice a year? How would you manage that?
So if he's currently getting his blood levels checked every 3 months, I would increase it at least at the initiation of the valsartan to probably every 6 to 8 weeks for the first probably 6 months and see how his kidney function does, as well as his electrolytes, as well as monitoring his blood pressure a little bit more frequently. If after that point he's not having any increase and there is no change, I think it would probably be appropriate to go back to the every 3 or 6 months that he was doing before.
After you've seen him fairly frequently, and then you taper off over time?
Absolutely.
Okay. Would you, at this point, encourage him, though, to stop the piroxicam? Again, because he's got chronic kidney disease, now he's got hypertension. What would your thoughts be?
I would ask him to stop it, or at least decrease it down to that every other day dosing to try to protect those kidneys just a little bit more. I would also ask him to exchange it for a different NSAID or a topical NSAID, such as the diclofenac gel. At least trying it for a couple weeks to see if that is effective for him.
I'm glad you mentioned that. That is the topical diclofenac gel, because he has left wrist pain. And, in point of fact, I wonder if we should have, perhaps in this patient, recommended the topical NSAID before the oral NSAID. Now, granted, he came to you already on piroxicam. What are your thoughts on the topical versus the oral NSAID?
I actually, especially in patients that have either GI complications or kidney problems or blood pressure, cardiovascular problems, I prefer to start with topical just because you don't get that internal organ effects. See if they respond to that therapy.
Mm-hmm. I see. And it sounds like you've done that in certain patients as well.
Yes.
That's an interesting point. Do you feel like the topical NSAID is less effective than, say, an oral NSAID?
I don't believe so. I believe it depends a lot on the patient's body habitus of whether they're going to get any effective relief from it or good effective relief from a topical. Obviously, the more adipose tissue or the more fat tissue that they have between the skin and the joint or the skin and the nerves below, I feel that they get a little bit less relief of their pain. Certain patients, you have more buy-in to that as well. And so they believe that it helps them. And that obviously helps me in not necessarily needing another oral NSAID on top of that.
Mm-hmm. Good point. I've found that patients who have osteoarthritis of the knee seem to benefit more from the diclofenac gel, the topical diclofenac product, compared to maybe some patients who have osteoarthritis of the hands or the shoulder. I don't know that all practitioners have seen that. What have you seen? Have you seen a differential analgesic effect from the topical agent in certain areas of the body?
Actually, ironically, I was having this discussion the other day because I feel that patients that I have been seeing have been getting a lot more relief in the ankles and knees versus the wrists and hand. Patients with the carpal tunnel aren't getting as much relief as I would like them to, and especially the joints with the finger joints with the osteoarthritis. They don't typically get as much relief as I see somebody with osteoarthritis of the ankle. They tend to be getting a lot more relief with topicals.
Mm-hmm. I've also found that patients don't necessarily apply it as frequently as they should. And I wish that there were an extended release preparation of this that they could just place on their joint once a day.
Absolutely. I have used the Flector patch in lieu in some of those patients when I can get the insurance to cover it. I have used the Flector patch in lieu of the diclofenac gel just because it's a little bit easier, less messier, and it can stay on longer.
But how do they use that on, say, the joints of their hands? I mean, it seems like, because they can't really cut it.
No, they can't. But unfortunately, some of them do cut it in long strips and wrap it around. And those patients say that they're getting relief. I have to believe it if they're telling me that.
Yeah.
I wish Flector would make smaller patches that would be more appropriate for hands and ankles and knees.
Now, if the patient's chronic kidney disease progressed while on the NSAID, what would you do?
I would highly recommend discontinuing the piroxicam and consider integrative therapies such as acupuncture, cognitive behavioral therapy for their analgesia.
Yeah, and you mentioned CBT or cognitive behavioral therapy earlier, and it sounds like you've had the patients in whom you've suggested that have had good results.
I have. You have to, like most therapies, have to have buy-in, and so they have to be willing to go down that road. That's a hard avenue to approach at times.
By the way, have you used acupuncture in patients who have, say, chronic wrist pain or osteoarthritis? And if so, have you found it to be effective?
Ironically, a couple days ago, I had a patient who has chronic neck pain, and there's a myofascial component to it as well as a cervical component to it. But we've done procedures on this patient. She has been on opioids in the past and is not willing to go down that road again at this time because of her work. And she is solely using acupuncture as her treatment at this point. She cannot take NSAIDs because she has peptic ulcer disease. So she prefers to stay away from that. And she is using acupuncture and has having significant relief of it.
Wow, that's terrific.
Yes.
Now, in this patient that you mentioned, what about using Celebrex or Celecoxib?
So she would be a great candidate for it, and we actually have talked about that. And when she finishes these next few sessions that she has with the acupuncturist, if the pain returns or if the acupuncture is not prolonged, that is something that she is definitely looking into using.
Or, I'm going to push you a bit on this too, or say using ibuprofen plus a PPI or an H2 antagonist. Would you consider that approach in this patient?
So it could be an option. She's not willing to go down that road herself.
Okay.
That's just not something that she wants. But, that in a worst case scenario, yeah, I would consider that therapy.
Let me ask you, Melissa, in general, how do you feel about managing this patient that we've talked about here with chronic kidney disease on an NSAID? Because, as I mentioned earlier, I think a lot of practitioners would say, wait a minute now, forget it. We're not going to touch this patient with an NSAID. How do you feel about it?
I personally don't have a problem with it. And although the clinical practice guidelines recommend avoiding NSAIDs in most patients with chronic kidney disease, in this case, it highlights the need to balance the risk and benefits of using the NSAID therapy in a case-by-case basis.
Yeah, and let me stop you there because I think that's key for, well, frankly, it's related to any prescription product that we recommend. I mean, it can be an NSAID, it can be an opioid, it could be a tricyclic antidepressant. There are a whole host of medications that we use to treat chronic pain, and it's all individualized. I mean, do you feel the same?
Absolutely. Obviously, not one drug works for everybody, or there'd be one drug on the market, and not every patient's going to respond to every drug in the same way, even regardless of the black box warnings. Some patients need the therapy. They may not be that person that's going to go down the road of what the black box warning was indicated for in the first place.
That's right.
So I do believe definitely in weighing the risks and benefits of the drugs and the patient's history and the patient's expectations of their pain management therapy.
That's right. And I think in this patient, in this clinical scenario, the potential risk of the chronic kidney disease progression from using piroxicam was really outweighed by the improvement in his quality of life from meaningful pain control with the NSAID.
Absolutely.
What are the key considerations in this patient then with respect to NSAID use?
Well, seeing the patient routinely to assess continued therapeutic efficacy of the NSAID. If it's no longer an effective analgesic, I wouldn't continue the medicine.
Right. Yeah, I agree. I mean, that's true for any medication that we prescribe, really.
Absolutely.
I just think that what happens, and this has happened to me sometimes too, is that I'll lose track of perhaps the fact that the medication isn't as effective as it was before, and therefore the patient just continues to stay on the medication. So I think for me, what I've learned in time is to make sure that I assess clinical efficacy, with every visit, and to specifically ask that question.
Absolutely. We tend to get stuck on pain scores and pain rating, but really truly saying if your pain score is still a 7, but how is it affecting your life? Are you able to continue doing the things you did before?
Yeah.
Maybe their idea of that pain score has changed, but their lifestyle has also significantly changed and it's not effective. Or they may not need as high dose as they did at one point.
That's
right. So
I
agree with you completely by continuously monitoring at each visit, their lifestyle and their expectations of pain and where they're at this point. And is the drug working any longer?
Melissa, with respect to the use of NSAIDs in general, what is your approach? I mean, that is, are you using them for both acute pain and chronic pain or not?
So NSAIDs in general, I think, are a great therapy. In acute pain, they're definitely a go-to medication for the short-term relief of any type of acute pain. Mm-hmm. In long term, I think they are a great alternative to or an adjunct therapy to anybody on chronic opioids or other medications or other modalities such as acupuncture. So I think NSAIDs are definitely a staple in pain management, both acute and chronic.
Melissa, it was great having you here today. Thank you.
Thank you very much.
Thank you for listening to Over-the-Counter Analgesics, Who, What, Which, and How Much, a 4-part series featuring Paul Christo, M.D. This program is supported by an educational grant from Pfizer. This has been a Dana Miller Video Network presentation.